Hello, Cardiothoracic Surgery colleagues from across the globe. Welcome to this edition of the Cardiac Recovery Room. I'm your host today, Ron Salinger. I'm the Chief of Cardiac Surgery at University of Maryland St. Joseph Medical Center. Join us every month to explore a new ERAS topic and related matters within cardiothoracic surgery. In today's episode, we will be exploring common and uncommon postoperative challenges after cardiac surgery. We are very lucky today to have two excellent guests who are here to share their expertise and insights on both common and uncommon problems after cardiac surgery. Specifically, we're going to be talking about vasoplegia and vasodilatory shock and postoperative atrial fibrillation. Our first guest is Subhashish Chatterjee, Associate Professor of Surgery and Director of Thoracic Surgery ICU and ECMO Program from the Baylor College of Medicine at the Texas Heart Institute.
Great to be here.
Our second guest is Amanda Ray, nurse practitioner and clinical program manager of cardiac surgery at University of Maryland St. Joseph Medical Center in Baltimore, Maryland.
Thank you for having me.
Well, let's jump into it. I think we'll start with vasoplegia and vasodilatory shock. Amanda, when you see a patient that's just come out of the cardiac operating room and is hypotensive, what's your general approach to that patient?
So my general approach is to assess all the data that I have available to me. And you need to make sure that you're making the right decision of what you're treating. You don't want to be treating a patient with a vasopressor who's having a cardiac output problem. And then you want to take the less invasive strategies before you go right to vasopressors. If you can pace them, if you have them too sedated, if you've given them too much pain medicine, things of that nature that we can kind of tailor back and maybe not have somebody as hypotensive as they are.
So the first thing you would do is make sure there's not something mechanical or some other cause of the low blood pressure besides vasodilatation. Make sure the heart's working okay, they're not bleeding.
Yeah, not acidotic.
Exactly. And then also look at like the drugs you're on, if any of the drugs, anything iatrogenic that you're doing that might be lowering the blood pressure. And then once you decide that they are vasodilated, what's your approach at that point? Do you have a general algorithm that you start to follow?
I usually start with norepinephrine. We usually tailor that up to, we do mics per kg per minute. So I would say around 0.8. I start thinking about adding a second line agent. But there is also good discussion about approaching this similarly to how we treat hypertension and using lower doses of different medications and maybe not increasing that high, because you're less likely to get some of the side effects that come with the high dosing of vasopressors.
And I would say that, we've looked at trying to develop sort of an organized framework to this. So I kind of use this as I've got two problems. One's a blood pressure problem, and one's this inflammatory cascade from the vasoplegic process that's shooting off like IL-1 and all these inflammatory markers and nitric oxide and whatnot. So I sort of conceptually think about it. Number one, what can I do for my blood pressure? That's norepinephrine, vasopressin, and angiotensin 2. And then on the other side, it's what can I do to get rid of this inflammatory response? So that's going to be like steroids, methylene blue, vitamin B12. And so the way I think about it, Ron, is I think about it, I need to go on offense with my blood pressure support medications and vasopressors, and I need to go on defense by trying to block the inflammatory response and kick it in like that.
I love that approach. When exactly are you kicking off some of your inflammatory, sort of like when you start your steroids? Like, do you have a regimented approach to when you do that?
Amanda, that's a great point. In order to compare apples to apples, you need something such as the norepinephrine equivalence. And so what that really does is that translates mics per kilo per minute of norepinephrine. So for example, 10 mics per minute in a 100 kilo person is 0.1 mics per kilo per minute norepinephrine equivalent. Vasopressin has a very comparable dose, so 0.04 of vasopressin, that's 0.1. And so right now, somewhere between 0.2 to 0.3, that's when we start to escalate. That's when I typically would do steroids. When we get to 0.3, and this is our institutional practice, that's when angiotensin 2 kicks in. And so, the way I look at it is some people ask, well, when do you do vitamin B12 versus angiotensin 2? How do you choose one versus the other? I don't see this so much as an either or problem. I see this more as a both and situation. I need both of them. I need one to get my blood pressure up quickly, and then I need another agent to mitigate the inflammatory response. It's going to take a little bit longer because the data is very clear. The longer you're vasoplegic, the worse your outcomes. I need to get them out of this quickly.
So do you use the norepinephrine equivalents to trigger both the offensive side of your dichotomy and the defensive side as well?
Exactly. So our institutional practice is 0.3 for angiotensin 2. I agree with Amanda's approach. I like doing combination norepinephrine, vasopressin. I think a little bit of each is better than a lot of another, but we're talking about people who are, quite vasoplegic. And then we typically will trigger steroids before we get to 0.2. I have a low threshold for steroids. I think early in the post-op course, as long as you monitor the glucose, remember, these are higher risk patients. These patients have considerably worse outcomes. There's an advantage to it. And then we do the methylene blue or B12 sometime somewhere between 0.2 and 0.3.
You keep saying institutional practices, and I know I have my own institutional practices, and I feel like cost gets weighed so heavily in the choices we make with vasopressors. I know in my head, I would probably choose things a little differently if that wasn't the case. What do you think about that?
It's a great point. We've actually looked at that if you look at 24 hours of use, the cost of 24 hours of vasopressin, angiotensin 2, methylene blue, and hydroxycobalamin are pretty similar. They're all about $2,100 US. That's off the FDA price. That's the wholesale price. That's not like our center getting a better cost advantage than another center. So they're really not that different. And I think the important thing is, the sooner you start this, the better. So we've looked at our own center, those patients we started on angiotensin 2 early in the operating room compared to those that we started later. Even though the same trigger, the people we started earlier, they needed shorter durations of angiotensin 2. They had better survival outcomes, better AKI outcomes, and it ended up costing less because the sooner we started the Ang2, the faster they came off of it.
Right, and the less the inflammatory cascade sort of shoots you in the foot.
Exactly. Amanda, what do you think's a mistake that people make out there or a misconception people have about vasoplegic shock?
I think it's misdiagnosed a lot. I think a lot of times people treat something as vasoplegic shock that's not something else. It's RV failure or some other, underlying cause. And I think then they end up doing a disservice to the patient by treating them for the inappropriate thing. And if I had to say, I would think that's probably the number one, because I think we're all pretty comfortable with vasopressors in cardiac surgery, right? So the dosing, the picking what you're using, making sure they're volume resuscitated, all that is not it. Yeah. I think it's missing something else.
On top of it, it's that this is a dynamic process. So just because at time 0, you've got one reason for shock, hypovolemic, hemorrhagic, doesn't mean that an hour or 2 hours or 4 hours later, things move around. It's dynamic. I joke around. The patient didn't read the textbook and only check off one box of the type of shock they're going to have. They can have multiple forms of shock. That's why you need to constantly reassess in your unit.
100%, I agree with that.
When do you guys think that someone crosses the line from just being a little vasodilated to being something that you should be more concerned about? Is it just the norepinephrine dose? How do you tell people in your ICU this is when we really need to make sure we're doing everything we can?
I think that this factors, you're looking at the patient as a whole. So you're looking at acid-base status. You're looking at lactate and lack of lactate clearance as mitigating factors. You're looking at the overall complexity. We know that there are patients who are at higher risk. We know that long operations with longer pump times and bypass and pump times are going to be higher risk. We know renal failure patients are at higher risk. A lot of transfusions are at higher risk. So if I know in the morning that this patient is a redo double valve with a creatinine of 2.5, I can pull the trigger pretty early on those sort of patients.
No, I agree. You have a lower threshold to start amping up what you're giving them so that you don't end up kind of behind the 8 ball. I guess I start thinking that I'm vasoplegic when I'm on high dose 2 and adding a third agent. I mean, I agree with you, markers, looking at the patient, all those things. Luckily, for most of it, it's a small percentage of our patients.
Yeah, what do you think in your units, just off the top of your head, how many percent of patients you think fall into that general category?
The problem with vasoplegia in an academic sense is that the definitions are so heterogeneous. Like, we looked at an analysis of I think 50 or 60 different publications, and literally there was 50 or 60 different definitions of vasoplegia.
Right.
So it's like playing darts, just throw whatever you want to call it. But I think a good consensus definition, I think it's probably somewhere between 10 to 25%. And that's degrees. There's mild, moderate, and severe. But real severe vasoplegia in our center, where we're using angiotensin 2 and B12 of these agents, less than 2% probably at that level.
Yeah, I would agree. If you're talking about super severe, probably very single percent numbers. But overall, I think when I'm talking two high dose agents, I'm probably talking 10 to 20% really, if we're talking two agents.
Can I ask a basic question? What do you target in this population, blood pressure-wise? Do you use mean arterial pressure, systolic pressure, a combination, both? And do you use an A-line? Do you prefer, what type of A-line do you prefer? Because we have all these discussions on round.
Really good question. I think if you're at more than 0.1, 0.05 to 0.1, I think an A-line is routine. Probably about 20 to 30% of patients have at least a 10-point difference in their map between a radial and a femoral arterial line. So I think you have to take that into account, just like in the operating room. So that's relevant. We follow mean arterial pressure more closely. You have to be careful in older patients they have the very high systolic and a low diastolic, because the map is 60%, influenced by diastolic. Sometimes you get a falsely known low number.
Plus, you have to remember, these are heart surgery patients. They're not septic patients. They just had their heart operated on. So if their diastolic blood pressure is low, they could get global. I mean, a lot of these patients have LVH on top of their vasodilatation.
Yes.
And they might not perfuse their myocardium.
Absolutely. You should take into account, sometimes in the sepsis literature, a map above 65 is the gold standard. I don't think that's satisfactory in post-cardiac surgery patients routinely. So, for example, your renal perfusion pressure or intra-abdominal pressure is your mean arterial pressure minus CVP. You need that above 60. So if I know I've got somebody with a CVP of 12 to 14, maybe a little RV dysfunction, somewhere around there, a map with CVP of 10, I want a map of at least 70 to 75 to give me a little bit of margin for renal perfusion.
I agree, because especially if you have somebody that comes in, since we're talking about cardiac patients, on all these antihypertensive drugs, and they're used to having a map of 90 to 95. A map of 65 is extremely too low for them, and we're going to end up with a lot of end organ perfusion, even if you're meeting this number goal that you've given yourself,
I have another question that I don't know if other people think about this, but sometimes if we do a case on a patient with an EF 25 or just a sick heart, and they come out, generally they're doing okay. Their heart looks baseline, but it's still a sick heart at baseline, but they're extremely vasodilated. Do you have, and say your thermodilution index is fine, it's 2.2, but do you have any qualms, like if they're on high dose vasoconstrictors, is any part of you want to add an inotrope to that, or is that wrong?
No, I think that's a good point. I think that you have to, sometimes I'll joke and I'll say, don't just do something, stand there. So for example, I want people in low EF patients to not be in a rush to wean inotropes. So the scenario you set up is you've got somebody with a low EF with probably some degree of vasoplegic shock. They're different, when you discuss inotropes. So for example, epinephrine is probably the first line in survey data. It's probably about 60 to 65% first line drug that people come off of, because there's an inotropic and chronotropic effect. Anesthesiologists love to come off on that.
I think it comes out of the water fountains in our ICU.
Exactly.
Yeah.
If you look at survival data and outcomes, this is true in cardiogenic shock. It's also true in cardiac surgery. Dobutamine and milrinone plus a vasopressor is better than epinephrine. Now, I'm not against epinephrine at the get-go in the initial phase, but I think if you're looking beyond 12, 24 extended duration, you should come off epi and go to something else. You're better off on dobutamine and a vasopressor rather than epi. But the person you described, fresh off the get-go, they're probably on epinephrine, which has both inotropic and vasoconstrictor effects. I'm not going to be in a rush to get that off.
Yeah, so some nitty-gritty points talking about, I at times will use milrinone coming out, post-op day 0, a few hours out. But you do often find yourself shooting yourself in the foot with the dilation, and you end up on higher doses of things because of that. So I agree. I usually will use a combination of like clofidipine and epinephrine if I need to. Obviously, we're talking about somebody who's not hypotensive, but I would almost rather use that for someone if we're just talking about milrinone versus that in an inotropic scenario.
Yeah.
The other question is, I know in my institution, some of these adjuncts that we use, vitamin B12 and the methylene blue, we generally use it as a bolus, but you use it a little differently.
We are pretty liberal about using methylene blue in the operating room. To give it, we typically advise 2 mg per kg.
Can you just again tell us when you hit that button, just for everyone listening?
So I would say somewhere between 0.2 to 0.3 norepinephrine equivalents. The difference between
Which is pretty high dose.
Yeah, I would say the difference between what experience has, and this is what you can't capture cleanly necessarily in a straight algorithm. What your experience teaches you is trajectory. It's a little bit like the great Wayne Gretzky quote, where he said, "I don't skate to where the puck is. I skate to where I think the puck is going to be." So I would say, as you develop experience, you don't just treat where the patient is at time 0. You think, where do I think this patient is going to be in 30 minutes and in an hour? And that's a little bit of understanding, pulling the trigger. I would much rather be more aggressive and be wrong than be more passive and be wrong, and then you start this vicious cycle. Because once you start that refractory acidosis and et cetera, AKI, then it's an uphill climb that you're probably not going to make.
Yeah.
Dr. Chatterjee, that is something that I like to refer to as AI, actual intelligence. And on that insightful comment, I think we can pivot and talk about a common postoperative problem, which is atrial fibrillation. I think everyone at the table and probably everyone listening has a vast experience with atrial fibrillation. And I wanted to just start off talking about overall approach for a cardiac surgeon that is seeing patients. How should they think about AFib and what should their approach be in general?
This is an opportunity for a cardiac surgeon and for a patient to potentially treat 2 problems at once. So a patient is referred with multivessel coronary disease or aortic stenosis or mitral regurgitation. I think it starts by asking, does this patient also have pre-existing atrial fibrillation? Through a combination of EKG, questioning, and trying to ascertain that, because that's an opportunity, if they screen positive for that, to actually intervene in the operating room. So the first thing you look at is, it's class 1 guideline. Can you do something surgically for the atrial fibrillation? So in mitral surgery, I think probably surgeons are really good about it, probably 70% of the time. But in aortic stenosis or coronary disease, probably less so. But you can argue that those are potential opportunities. So that's where it starts.
Great. Amanda, you and your team see a lot of preoperative patients. What types of questions do you ask to see if maybe that patient has undiagnosed atrial fibrillation that can be addressed?
Usually they're fairly simple things, like have they had palpitations before or have felt like their heart skips beats or things of that nature. If anyone's ever told them that they've had an arrhythmia or they've ever had an EKG, mostly those type of things, kind of simple questions.
I agree. I think it's screening history, in terms of that. And I think sometimes, the patient may not remember, but their spouse does. And so I think that's the value of it.
And then we're saying, if you have the time pre-op, then maybe put a monitor on that patient if it's an outpatient and you can do some screening.
I think there's a role for that in appropriate settings.
We definitely catch it inpatient, right? Somebody comes in, has an MI, has to have a washout. We have them on a monitor for a couple of days and catch them in AFib when they didn't know they had it.
There's no question that it seems like surgeons have gotten a little bit better about managing the left atrial appendage, but that surgical ablation is still severely underutilized. And the evidence behind it it's one of these things where the evidence is very strong, but the surgical community is not as convinced for several reasons. What do you think are some of the barriers that are keeping patients from ablating more patients when they're we're talking about concomitant ablation. Someone's already going to the OR.
So in mitral surgery, I think it's much easier because the atrium's opened up and it's much easier to go ahead and do that. So I think surgeons are much better at mitral surgery. When it comes to aortic stenosis, so for example, sometimes that becomes a question of, well, I'm doing it minimally invasive. And, there's a trade-off. Can you do a good minimally invasive, whether it's a right anterior thoracotomy, can you still do a good ablation procedure? Because nowadays, pulmonary vein isolation itself isn't as reliable. So can you do a full maze and preserve it minimally invasive? So I think in aortic valve surgery, that's probably a limitation.
I would take a good solid pulmonary vein isolation. I would say, while it's not as good as a maze, it's far better than doing no ablation at all.
That's fair.
Or it's better than doing no ablation at all, let me say that.
Yeah, I think that's fair.
Especially if you combine that with left atrial appendage management.
Right. And I think coronary disease, I think it's a question of introducing the complexity of it. And, in terms of that, I think there's probably a little bit of a feeling that, well, this patient was anticoagulated on AFib. Whatever I do, the patient's still going to be anticoagulated post-op, regardless of my maze result. And I just want to get him through the procedure. And I think that's it. I think the way that even though there's a survival advantage, there's a 30-day survival advantage, I think it makes a difference when the referring cardiologist asks for it. So I think if a referring cardiologist said, you know what, this patient has both coronary disease and AFib, can you address both of them?
In general, as we all know, we reward surgeons for their short-term outcomes, but there's no accountability for longer-term outcomes. Do you think if we did something in the databases, in the quality metrics relating to whether or not a concomitant ablation was performed, that would change practice? And do you think we should do something like that?
I think it might move the needle some, because obviously there's more stakes in the game. I don't know. That's actually probably a good question for you.
I feel like that's how we got surgeons, parenthetically before I was in practice, to adopt LEMA usage, was by making it a quality metric. And I think the data behind concomitant ablation is as strong, maybe stronger than it was at that time to use a LEMA.
Right.
So I think it's warranted. I think it's something our society should seriously consider.
If you do, say, a single mammary graft and two veins, which is still the most popular coronary procedure in the United States, and the patient has AFib, I would rank the mammary to LAD graft as probably priority number one. Closely behind is an ablation procedure to get him out of AFib. And then far lower in priority, probably the circ and the RCA graft in terms of long-term survival.
I agree with that. I think concomitant ablation for a patient with AFib is more important than a second arterial conduit. I agree. There's definitely people who would say it may be more important than the mammary. I'm not sure I'm convinced of that, though. All right, let's pivot a little bit and let's talk about postoperative AFib. Shubha, I know you've published on this. Amanda, you have vast experience with this. What would you say are our best preventive strategies for postoperative AFib?
It starts in the operating room. Sometimes it can even start pre-op. Like there's data that supports preoperative use of amiodarone. In general, that hasn't been widely adopted because it's harder to monitor these patients, like when they're in an outpatient and people are a little reluctant. But in the operating room, I would say that often an underutilized technique is posterior pericardiectomy, which is basically cutting a hole in the pericardium so that blood from the pericardial space dumps into the left chest. Because a lot of post-op AFib is hypothesized to be due to the mediastinal shed blood irritating the epicardial surface. So that's one opportunity. Interestingly, there are some preventive strategies. Like some people are actually doing preventive left atrial appendage occlusion. We didn't get a chance to talk about that in the previous segment. Left atrial appendage is a clear benefit at 5 years in reducing stroke. So some people are doing it prophylactically.
And be clear for the audience, that's for patients. That's been shown definitively for patients with AFib.
Exactly. So left atrial appendage, definitely guideline recommended in patients with AFib. Now, the question is there a benefit in prophylactic left atrial appendage?
To your prior point, that is being pushed hard by the referral community.
It's interesting.
To manage the appendage. If you take a patient with AFib to the OR and don't manage the appendage, the cardiologists have something to say about that.
Yeah, and I think that's good. I think that's good.
Agree. I think it's very good.
I think that's good. I think when you look at prophylactic left atrial appendage, that data is far less robust. There are ongoing trials on that. You are taking a short-term increase in post-op AFib. When you manipulate the appendage, you're going to cause some early AFib. The question is, 5 years down the road, do you prevent a stroke or any other thromboembolic events? We don't know. But going back to preventive strategies, your class 1 indications are amiodarone for prevention, beta blockers for prevention. Data is comparable in terms of number needed to treat, probably somewhere between 6 and 8 if you look at it. I actually think the data is a little bit better on prophylactic amiodarone than it is on beta blockers. But beta blockers are a quality metric, so that tends to be the first line most people tend to use.
And would you say that beta blockers may have more other potential benefits that amiodarone may not, other than if you're not just looking at the AFib prevention?
It's possible. I do think that the approach we've tended to take is being more aggressive with prophylactic amiodarone in the first 48 hours, and then ultimately pivoting to beta blockers, because the quality metric is to be discharged on a beta blocker. They don't give you more points for being on a beta blocker day one.
Are you putting everyone post-op on IV amio?
We're working through that. So right now, that's our default approach. We're doing that a little bit in a sort of a QI sort of initiative. But our default is to more aggressively use amiodarone as a prophylactic measure. Now, obviously, there are people you shouldn't do that on. Are they pacing? Are they bradycardic to begin with? And there's some other small indications, but that's something to be mindful of.
And what's been your approach in your unit? And what kind of issues have you seen both with beta blockers and amiodarone?
I was actually going to ask you that question. So if we see people even having 3-second blips here and there, we're pretty aggressive with starting them on a PO load. We do not prophylactically give everybody amiodarone. Problems come with that, as you said, bradycardia. You can get some transaminases elevated sometimes. Sometimes people just don't feel well on it. They're nauseous. I would say those are probably the main ones that you see. You get amiotoxicity, and occasionally you get somebody with some lung infiltrates from that. But that's probably more of a rare.
Nausea seems pretty common. I mean, just from rounding, I don't know.
From oral amiodarone.
Yes.
IV, it's less. We do 2 grams over 48 hours of IV amiodarone.
2 grams.
Yeah, and then just over 48 at a
so
lower
you don't
dose.
give a full load.
No, not for a prophylactic.
Cardiologists have an opinion on that, or?
No, I think early our prelim data, we showed a little bit of a reduction, but we're also looking at it in a comprehensive approach. I mean, and I think that's really what I think, in our ERAS guidelines, that was really ultimately, I think, the approach that we took. There are a bunch of things that you could do. You should have a systematic approach, to be able to do that, in terms of that. We looked at all the amio beta blockers, posterior pericardiectomy, to be able to see that. There are 3 sets of guidelines, cardiology guidelines, European guidelines, Canadian guidelines that have different recommendations. I was fortunate to be a part of the Society of Thoracic Surgeons that are issued, a set of recommendations, early next year. So, that's an opportunity.
Amanda, let me ask you a question. Shift a little bit and say, let me give you a scenario. We have a 66-year-old man, has a CABG ×4. He's doing great the next morning. You take all his lines out, you send him to the floor, he's on a beta blocker, and then he has a great day. And then the evening of post-op day 2, you get a call, his heart rate's 160. Blood pressure's fine, he's over there, he feels a little anxious. What's your approach to that patient?
So for somebody who's an RVR, I would usually give them an IV amio bolus, then sometimes follow that with a cardizem drip or an amio drip, probably a cardizem drip if they have enough pressure for that, and then work on trying to convert them.
And does your use of amio PO or IV depend on IV access, or how do you decide that on a patient on the floor?
On a patient on the floor, you do want to have good IV access because it can be a little caustic to the vein. But if somebody's an RVR, I think it's more important to get it in them quicker and through an IV. At
what point do you go from just controlling the rate to wanting to get them back in sinus, or do you not worry about that? When do you try to control their rhythm?
definitely if they're unstable, I would try to cardiovert them out of it more quickly. Some people, I get that's ACLS, but some people don't necessarily agree with that unless you've already loaded them with things. But I would try to cardiovert somebody out of it if they were unstable.
Let's say a stable patient, you get their heart rate under 100, but they are still an AFib. They don't have a history of AFib, otherwise looking good. Do you cardiovert them? Do you try to get them in sinus rhythm before they discharge?
This is highly variable. The CTSNet trial that Gilinov and colleagues published probably approaching 10 years ago essentially came down to, did you have an initial rate control versus initial rhythm control strategy? That trial basically came out equivalent. This primary outcome was rehospitalization at 60 days or the hospital days at 60 days. If you look at, there's a soft hint at maybe at 7 days, like a 1% to 2% higher rate in the rhythm control. But if you look at 30, 60 days later, it's really equivalent. So that was the conclusion, that whether you took an initial rate or rhythm control, the results were similar. Now, that trial had certain challenges to it. For example, there's about a 25% crossover. So about 25% of the time, the rate control group got frustrated, switched them over to the rhythm strategy, and about 25% of the time, the amiodarone group couldn't tolerate it, so they switched them to the other. So it's hard to really interpret like what it is. Essentially, that study basically said, if you're a primary rate control person, stay with it. If you're a primary rhythm control person, stay with it. So that would be the way to interpret that. Now, the question you're asking is, how important is it to get them out of atrial fibrillation back into sinus rhythm? It comes down to a couple things. One is there a difference in clinical outcome? I don't think we know that. I think that the CTSNet trial and a couple of other trials, I don't know if it's very clear one's better than the other. But that doesn't mean that it doesn't mean anything. There are people who are in rate-controlled AFib and feel miserable and they just don't feel as good. Maybe those are people who would benefit from getting them out of it. There are people where the decision point is, if they are in AFib, they're going to get discharged on anticoagulation. If they're not in AFib, they won't be. So it behooves me to get them out of AFib, however means necessary, so I don't feel forced to be able to anticoagulate them.
And I'd also say there's a small subset of patients who, even if you've rate controlled them, that AFib rhythm, it really does a number on their cardiac output and sort of their end organ perfusion. And so you think at times you have to look at patient per patient. What is this patient not tolerating? It may be just the AFib.
Yeah, I think some patients that come to mind for me, that like the left ventricular hypertrophy patients, the mitral stenosis patients, those like very stiff hearts. Yeah. They really don't seem to like the AFib.
Low EF, aortic stenosis, agree.
And I feel like we've watched the cardiology community to some extent go through this exact debate, and the pendulum has swung very much towards rhythm control in their literature. But you mentioned something that's a good segue to our next topic, which is anticoagulation. Who should be anticoagulated with postoperative AFib, and who do we not have to anticoagulate? And what are the considerations? What are the risks? What are the benefits?
The short answer is nobody knows. And unfortunately, that's also the long answer. So let me take a stab at it. So the American College of Cardiology guidelines are a 2A recommendation. The European guidelines were a 2B and now a 2A. They kind of have gone back and forth. The Canadian guidelines are a little bit more like a thoughtful, deliberative, like watch and wait. The challenge here is we know that patients who develop AFib are more likely to have a bad outcome. Whether that's because of the AFib or whether that's because these tend to be higher risk patients to begin with, older, lower EF, etc., that's not clear. So how much of an independent factor is post-op AFib in terms of early and later outcomes? So that's one question. So we think that it's a little bit worse in the AFib group. The second question is, does anticoagulating those patients who develop AFib reduce thromboembolic events without causing harm? And that data is not compelling at all. And I think this is probably the biggest disagreement that we on the surgical side have with interpreting cardiology. Cardiology is very clear. CHAD's VAS greater than 2. AFib equals anticoagulation. It's a default. It's the first line. But post-op AFib appears to be a slightly different phenotype. The risk profile is different. It tends to be more RVR. It tends to be much more shorter lived. When you do telemetry and Holter monitoring, it's really surprising. Most of these patients will have a short blip of AFib, but it's far less even when you send them home than people imagine. The data is not there that shows that anticoagulating patients consistently reduces thromboembolic events. Specifically, the largest STS registry data shows very clearly no benefit in thromboembolic events, a much greater, nearly threefold higher greater in bleeding events, and a slightly higher risk of mortality. So the data, registry data, putting the systematic reviews together, there is really very, very little good data that shows anticoagulating patients with AFib is beneficial.
So with that being said, for me personally, we do it at about 24 hours. If somebody's had 24 hours of AFib, we start talking about anticoagulation. And that doesn't necessarily mean they'll get it. If they have a low CHA2DS, if their appendage was taken, if they have other factors that we're concerned about, we may not. But what's your threshold to decide that you're going to send somebody home on that?
It's a good question. So I don't think there's anything to say like duration of AFib or, they got a second episode or a third episode. I don't think there's any relationship between that and risk of stroke. What I would say is that there's a sweetheart registry. So this is Sweden's interesting because basically all their post-op cases can get into a national database and registry, and you can track those outcomes well. You do see in CABG patients, after somewhere between a CHA2DS of 4 to 5, there's a suggestion that there might be a benefit to anticoagulation. Again, a little bit harder to interpret, but that's probably, so we're talking about a very high risk group there. So I would say that would be the trigger. I think that in mitrals, in valve surgery, I think you have a lower threshold to anticoagulate. So in general, the number needed to treat is probably it's much lower, in CABG.
The evidence supports that.
Yes, exactly.
And Amanda, once you decide you're going to anticoagulate someone, what agent do you like to use and how do you decide that?
Usually we use a DOAC. That's very dependent upon the patient's pharmacy and their insurance plan and how much that's going to cost them, which one we use.
The PACES trial is, I think, close to being done recruiting. So that's going to address DOAC, or direct oral anticoagulant like apixaban or rivaroxaban versus vitamin K antagonists like warfarin. The good data does not really say that one's better than the other. The traditional, experience in the cardiology AFib literature is that DOACs very consistently don't necessarily reduce the risk of thromboembolic events compared to warfarin, but are associated with lower bleeding complications, which is obviously beneficial in the perioperative state.
And also, you don't increase your length of stay by waiting for somebody to become therapeutic on Concomitant,
right,
or having them have to go get draws throughout that time. So I think you also have to weigh that mitigation of extending their stay and what are you putting at risk for that.
The anticoagulation question I find to be very difficult because there's a lot of uncertainty, but there's our closely related specialty in cardiology, which, as you rightly point out, doesn't have this high bleeding risk, but they're very confident that the patient should be anticoagulated. And I know a lot of surgeons that feel like they're exposed if they send a patient out with AFib and they don't anticoagulate them and they come back with a stroke. And they feel like they're almost, because of the uncertainty on the cardiac surgery side and the certainty on the medical side, they feel obligated to anticoagulate.
I think that's real. I think there is a medical legal element to it. I think I looked up once, I did a Google search on post-op AFib medical legal, and I think the first 15 searches were all basically malpractice law firms advertising, did you have a stroke afterwards? That's for real. That's a real thing. That's why I think you need good quality studies, but you also need smart guidelines that help basically say that you need to weigh the risk and benefit to that. I do think it starts by appreciating what the benefit is, and these are two distinct phenotypes. Regular standard atrial fibrillation, what used to be called non-valvular atrial fibrillation, that's still the majority out there, is different than post-op AFib. Most post-op AFib, you could do nothing and most of it's going to go away.
Yeah, I think that's a great point. I'd like to give you each time to wrap up. Amanda, could I ask you to give us your final thoughts on vasoplegia?
Yeah, so I guess my final thoughts on when you're treating vasoplegia is make sure you're not mistreating something else. And I think I'm a believer of the lower dose and using more agents. I think I have more success and less side effects from it. So I think that's something to consider when you're practicing.
Great. Shubha, can I ask you to give us some parting thoughts on the most important thing about the huge topic of AFib?
I think you need a comprehensive approach. It starts in the clinic to address atrial fibrillation pre-existing. I think you should do as many preventive steps as you can to reduce the risk of developing AFib. I think you have to think of AFib not as a nuisance, but as a complication. I think there's probably a really good element. If we considered this a complication, I think sometimes people would see it, in terms of precautions taken. And then I think you need a thoughtful, deliberative strategy weighing the risks and benefits.
That's great. Well, I'd like to thank both of my distinguished colleagues for sharing their time and expertise, and to the audience for listening. Join us for next month's episode and our next podcast in the Cardiac Recovery Room.